All right, so we're doing chapter 22, assessment of the respiratory system. The priority concepts are gas exchange, and the interrelated concepts are perfusion. So remember, for effective gas exchange to occur, the alveoli of the lung must be ventilated and perfused. Ventilation refers to the flow of air into and out of the alveoli, while perfusion refers to the flow of blood to the alveolar capillaries. Gas exchange occurs at two sites in the body. That's the lungs, where oxygen is picked up and carbon dioxide is released at the respiratory membrane, and at the tissues, where oxygen is released and carbon dioxide is picked up. External respiration is the exchange of gases with the external environment, and it occurs in the alveoli of the lungs, whereas internal respiration is the exchange of gases within the internal environment, and this occurs at the level of the tissue. All right, so the next thing it talks about is heredity, changes that are associated with aging. Heredity significantly influences lung aging and also the risk for disease. It affects the lung development, the baseline function, and puts patients more susceptible to conditions like COPD or pulmonary fibrosis. They also experience decreases in peak airflow, and that's how quickly someone can exhale due to decreased elasticity of the lungs. They also have a decrease in measures of lung function, such as vital capacity. Vital capacity is the maximum amount of air that can be breathed out following a maximum inhalation. The rib cage bones get smaller. They also experience a weakening of the respiratory muscles. They also experience a decline in the effectiveness of lung defense mechanisms. Older adults are at higher risk of developing pneumonia after a bacterial or a viral infection. That's why vaccines are very important. The influenza vaccine, the pneumococcal pneumonia vaccine, and the RSV vaccine. They're very important for older adults. Importantly, age-related changes in the lungs are compounded by the effects on the heart and lung disease, especially those caused by the destructive effects of smoking. All right, so the health promotion and maintenance is to avoid secondhand smoke. That's around those who smoke. Third hand is indirect contact, so exposure to the smoke through clothing and hair. We need to teach to use masks or respirators if working with dust, chemicals, or allergens. And aerobic exercises, walking, cycling, swimming. These can boost lung capacity and efficiency. Also help strengthen muscles to help breathe more effectively. Keep them hydrated. Water thins mucus, making airway clearance easier. And a healthy diet that includes antioxidants, rich foods like berries, green leafy vegetables. They protect lung tissue. And also maintain healthy weight, reduce the strain on the respiratory system. All right, so then it talks about smoking cessation protocols and the 5 A's. Remember, the 5 A's are ask, routinely screen every patient about tobacco. Do you use tobacco products? Advise them strongly to quit, in a firm and personalized manner. Quitting is the best thing for your health. Then assess, determine if the patient is willing to make a quit attempt in the near future, and assist, help the patient quit by providing resources, developing a quit plan, and discussing meds like the NRTs and counseling. And then arrange, schedule follow-up appointments in person or by phone to check on progress and provide ongoing support. Bupropion is a medication that can help with the craving. It's an antidepressant which doubled as abstinence rates by affecting dopamine, norepinephrine, and blocking nicotinic receptors. So it reduces the nicotine reward and eases withdrawal. And then you got the varenicline, brand name Chantix, reduces nicotine cravings and withdrawal symptoms. It works as a partial nicotine agonist. It's also used as a nasal spray for dry eye disease. And then they've got nicotine lozenges, gums, and patches as well. All right, so then we move into the assessment. Okay, we have to assess for things such as paroxysmal nocturnal dyspnea. That's sudden severe shortness of breath that wakes you up from your sleep, typically 1 to 2 hours after falling asleep, making you feel like you can't breathe and forcing you to sit or stand up for relief. That's called orthopnea. It's often accompanied by gasping, coughing, and anxiety. Remember, packs a year is the way you figure this out is to multiply the packs the patient smokes per day, and then you multiply that by the many years that they've been smoking. So if I'm a pack a day times 20 years, I'm 20 pack. Okay. All right. Then the assessment continues. So we have to assess the level of consciousness. The patient should be alert and cooperative. Look for signs of hypoxemia, low blood levels of oxygen, or hypercapnia, which is high blood levels of carbon dioxide. This can cause a decrease in level of consciousness. Also, irritability, anxiousness, restlessness, and confusion. Obtain the respiratory rate over a full minute. The normal range of the respiratory rate in an adult is 12 to 20 breaths per minute. Observe the breathing pattern, including the rhythm, the effort, and any use of accessory muscles. Observe also the depth of respiration and note if it's shallow or deep. Look for pursed lip breathing, nasal flaring, or any audible breathing, any intercostal retractions, anxiety, and use of accessory muscles, because these are all signs of respiratory difficulty. Patients who experience difficulty expelling air, such as those with emphysema, may have prolonged expiration cycles. Some patients may experience difficulty with breathing, specifically when lying down. Again, this is known as orthopnea. Additionally, patients who are experiencing significant breathing difficulty may experience most relief while in a tripod position, where they're sitting up, leaning forward. Now, crepitus. This is a popping or crackling sensation when the skin is palpated, and it's a sign of air trapping under the subcutaneous tissue. You got to make sure you place the stethoscope properly during auscultation to obtain quality assessment. It should not be performed over clothes or hair because these may create inaccurate sounds from friction. The best position to listen to lung sounds is with the patient sitting upright. However, if the patient is acutely ill or unable to sit upright, turn them side to side in a lying position. Avoid listening over bones such as the scapula or the clavicle or over the female breast to ensure you're hearing adequate sound transmission. Listen to the sounds from side to side rather than down one side. This side-to-side pattern allows you to compare sounds in a symmetrical lung field. Now remember, expected lung sounds are called bronchial. These are breath sounds heard over the trachea and the larynx and are high-pitched and loud. There is also bronchiovascular. These are sounds of medium pitch and heard over the major bronchi. And finally, you have vascular. Vascular is breath sounds heard over the lung surface. These are lower pitched and often described as soft, rusting sounds. And then you have your adventitious sounds. They most often indicate an airway problem or disease, such as accumulation of mucus or fluid in the airway, obstruction, inflammation or infection. And these sounds include rales, which we know as crackles, rhonchi, which is a form of wheeze, stridor, and a pleural rub. Now, a fine crackle is also called rales. These are popping or crackling sounds heard on inspiration that occur in association with conditions that cause fluid to accumulate within the alveolar and interstitial spaces. These conditions are heart failure or pneumonia. The sound is similar to that produced by rubbing strands of hair together close to your ear. Then you got wheezes. These are whistling type noises produced during expiration and sometimes during inspiration, which is actually a worsening sign. This is when air is forced through airways that are narrowed by bronchoconstriction or associated mucosal edema. So those that have asthma commonly have wheezing. Then you have stridor. This is heard only on inspiration. It is associated with a mechanical obstruction at the level of the trachea and the upper airway. And then you have the pleural rub. This may be heard on either inspiration or expiration, and it sounds like a rubbing together of leather. A pleural rub is heard when there is inflammation of the lung pleura, which is the sac that surrounds the lung, and this results in friction at the surfaces as they rub against each other. All right, so other indicators of respiratory adequacy: observe the color in the lips, the face, the hands, and the feet. Patients with light skin tone should be pink in color, and for those with darker skin tones, assess for pallor on the palms, the conjunctiva, or the inner aspect of the lower lip. Remember, cyanosis is a bluish discoloration of the skin, lips, and nail beds, which can indicate decreased perfusion and oxygenation. Pallor is the loss of color or paleness of the skin or mucous membranes, and usually a result of reduced blood flow, oxygenation, or decreased number of red blood cells. So you need to inspect the chest for symmetry and configuration. The trachea should be midline and the clavicle should be symmetrical. Note the location of the ribs, sternum, clavicle, and scapula, as well as the underlying lobes of the lung. Okay. Remember that infants up to 3 months of age are considered obligate nose breathers, meaning their breathing is primarily through the nose, so nasal congestion can limit the amount of air getting into the lung. A technique that we can do is called percussion. This is an advanced respiratory assessment technique that is used by advanced practice nurses and other healthcare providers to gather additional information about underlying lung disease. You can do this by striking the fingers of one hand over the fingers of the other hand. A sound is produced over the lung that helps determine if fluid is present. Okay, so dull sounds are heard with high density areas such as pneumonia and atelectasis, whereas clear low pitched hollow sounds are heard in normal lung fields or lung tissue. Okay. All right. Then it talks about the psychosocial assessment. Assess for anxiety and depression. There's a high prevalence in chronic respiratory disease such as COPD and asthma, creating a cycle where anxiety worsens breathlessness, which causes dyspnea, and vice versa. Also, illness perception. Ask how the patient understands their condition, and because this can affect management and anxiety. Also, trauma, fear of being breathless, post-traumatic stress disorder, and nightmares are common after severe respiratory failure or mechanical ventilation. You also want to assess their social support. Make sure they got a network of family, friends, or caregivers. Their living environment, their home conditions, especially any potential allergens like pets or dust. Occupational exposure, past or present jobs. Have they worked around asbestos or farming? Are they using any substances? Do they smoke, drink alcohol? And what their activities are. Are they getting enough exercise? What are their hobbies? What is their ability to perform daily tasks? So how self-efficient are they? Okay, then we move into the lab data. Okay, so the red blood cells are vital for transporting oxygen. Remember, they're the car from the lungs to the body tissue and carrying carbon dioxide back to the lungs. So an abnormal red blood cell count can indicate underlying respiratory issues of the body's attempt to compensate for poor lung function. Arterial blood gases is the best measurement of lung function. It measures how well the lungs oxygenate blood and remove carbon dioxide. This can reveal gas exchange efficiency and the body's acid-base balance. It's essential for diagnosing lung disease like asthma or COPD, and also evaluating treatment effectiveness like oxygen therapy and managing critical conditions like acute respiratory distress syndrome, sepsis, or even respiratory failure. The sputum specimen can diagnose infections like pneumonia, bronchitis, or TB. They can identify specific germs, bacteria, fungi, or viruses, and they can guide the effective antibiotic treatment. They can also monitor chronic lung disease flare-ups like COPD or cystic fibrosis, and they can detect abnormal cells for lung cancer and reveal the cause of cough, colored mucus, and breathing difficulties. Then you got the CT, computed tomography. It's a detailed cross-sectional image of the lungs and chest. It can reveal abnormalities like nodules, infections, inflammation, and blood clots like pulmonary emboli and tumors. Then you have the pulse ox, uses a wave of infrared light and sensor placed in the patient's finger, toe, nose, earlobe, or forehead. Then you have capnometry. This is a non-invasive measurement of the amount of carbon dioxide in an exhaled breath. Capnography adds a waveform called a capnogram to that number, offering a more complete picture of ventilation, metabolism, and then circulation. Then you got the pulmonary function test. You got spirometry. That's the most common. It measures inhaled, exhaled volume and speed, and it's often using a mouthpiece and machine. Then you got body plethysmography. You sit in a booth to measure lung volumes by tracking pressure changes from your breathing. Then you have a diffusing capacity test, which measures how well gases transfer in the tiny air sacs called the alveoli. And then you have exhaled nitric oxide. This checks for airway inflammation, and this test is often linked with asthma. Okay. All right, so invasive diagnostic assessments, you have what's called a thoracentesis. A thoracentesis is when we can remove fluid from the pleural cavity, inserting a needle between the ribs. Clients are at risk, though, for developing pulmonary edema or cardiovascular distress because of mediastinal content shifting of fluid after the aspiration of large amounts of fluid from the client's pleural space. Therefore, the client may experience an increase in heart and respiratory rate, along with coughing with blood-tinged frothy sputum and tightness in the chest. These findings require notification of the provider immediately. They also could develop hypotension if too much fluid is removed, as the other fluids in the body begin to shift due to changes in equilibrium. They also could develop an infection at the site of the needle puncture. You got to make sure for this procedure you position the client in an upright position, leaning over the bedside table, and tell them they're going to have to hold still. Okay. All right, then we got this question here. The nurse is assessing an older adult client. Which assessment finding requires nursing intervention? That would be A, tightening of the vocal cords, and D, decrease in anterior-posterior diameter. Okay. In the normal aging process, the vocal cords become slack, which changes the quality and strength of the voice. Okay. And if there's a decrease in the anterior-posterior diameter, that indicates barreling. Okay. All right. So that does it for that chapter. So then we'll head into 25. Okay. All right, concepts of care with patients with infectious respiratory problems. Okay, it says the priority concepts: gas exchange and infection, and interrelated are cognition, immunity, and inflammation. So the first thing it talks about is seasonal influenza. It's very prevalent in fall and winter. It's spread through respiratory droplets, and while most cases are mild, the flu can lead to hospitalization or death. So you have to emphasize getting those vaccinations and hygiene for prevention. All right, so it talks about the pandemic influenza. An antigenic shift is a dramatic genetic change when human, animal, and avian flu viruses mix, which creates a new virus in pigs or birds, and it can lead to a pandemic, which is something that affects the entire world. The impact: high illness and death rates, It'll cause economic disruption and strain on services like schools, transportation, and healthcare. So the Centers for Disease Control and the World Health Organization monitor for global flu viruses. The teaching is hygiene, staying home when sick, and using masks in crowded areas. Okay. All right. So gas exchange concept, it talks about pneumonia. This is an inflamed alveoli. It can become filled with fluid or purulent material. So lobar pneumonia is a distinct pattern of bacterial pneumonia where a whole lobe becomes solid, affecting oxygen exchange, and can progress through stages, which include congestion, hepatization, and resolution. And this requires prompt medical treatment with antibiotics. All right, so it says organisms such as bacteria, viruses, mycoplasma, fungi, rickettsia, protozoa, and helminths all can cause pneumonia. And the non-infectious causes you see here, community-acquired, healthcare-acquired, and ventilator-associated pneumonias. So non-infectious pneumonia, also known as non-infectious pneumonitis, is lung inflammation that's not caused by a germ, but by irritants like inhaled dust, chemicals, smoke, certain meds like chemo meds, heart drugs, or from aspiration. Okay. Now, the bacterial type is usually caused by Streptococcus pneumoniae. It's the most common bacterial cause, and that usually follows a viral infection. Then you got the Mycoplasma pneumoniae, causes mild or walking pneumonia. And you got the Haemophilus influenza, which is another significant bacterial cause. And then the Legionella pneumoniae, causes severe Legionnaire's disease. You also have Staphylococcus aureus or MRSA, which can cause drug-resistant pneumonia. The viruses, you've got influenza, the RSV, which is the respiratory syncytial virus, COVID-19, and human metapneumovirus. Okay, and then the fungi can also cause it too, but that's usually those that have a weakened immune system, like those with HIV. All right, so then it just describes here the difference between community-acquired and healthcare-associated. Remember, the thing that you really want to pay attention to is 48 hours. If you present with symptoms before the first 48 hours of admission, you got it in the community. If the symptoms don't start until after 48, you got it in the hospital. Okay, and then it just goes and shows you what ventilator, same thing. If you get the symptoms within 48 hours of being placed on a ventilator, okay, you didn't get it on the ventilator, but if it's after 48 hours, you got it on the ventilator. All right, so then it just talks about stats here, incidence and prevalence, 2.5 million cases a year, higher among older adults, nursing home residents, those that live in enclosed spaces with large numbers, and especially because they're elder, so they have a depreciated immune system. The health promotion and maintenance, we have to preach these things, get your vaccines, stay away from large crowds, cough, turn, move, deep breathe, so don't be immobile, clean respiratory equipment appropriately, avoid pollutants, don't smoke, get rest, eat right, and get adequate fluid to thin out those secretions so they don't pull. All right, so then it goes into the assessment. It says here, the patient may have chest pain or discomfort, myalgia, headache, chills, fever, cough, tachycardia, some dyspnea, some tachypnea. They may have blood in their sputum called hemoptysis and sputum production. Also, severe chest muscle weakness may also be present from coughing so much. So you have to observe their breathing pattern, position, and use of any accessory muscles. The patient with hypoxia and reduced gas exchange may be uncomfortable in a lying position, orthopnea, and will sit upright, balancing with the hands, and they will assume what's called the tripod position. So you need to assess the cough and the amount of color, consistency, and any odor of the sputum if they're producing sputum. Okay, so you have to recognize the cues. There's the lab test that we can use. They can gram stain it to see what type of bacterium it is, gram positive or negative, to determine what's going to kill it. can look at the CBC, look at the white blood cell count, do blood cultures, ABGs, all the tests that we talked about earlier. All right, it says effective care coordination and transition management for pneumonia are critical to reducing high 30-day readmission rates. Focusing on a three-pronged approach of medication reconciliation, making sure they're on the right meds, post-discharge follow-up, and patient teachings or education, very important. All right, so it talks about empyema here. That's pus in the pleural space, the sac that surrounds the lung. And that's hard to aspirate. We can aspirate fluid, but not pus. It says when evaluating goals, remember time frames and expected 1 to 2 week recovery for mild cases. It may take 2 to 3 months for moderate to severe cases. Effectiveness depends on three main factors: how well they're ventilating the alveoli, diffusion capacity across the membrane, and pulmonary perfusion, meaning is it getting adequate blood flow. All right, so then it talks about pulmonary tuberculosis. Okay, very, very contagious, transmitted through the air. It can cause secondary TB. Now, the symptoms, they're going to have a persistent cough, usually more than 3 weeks. They'll be coughing up blood or mucus, chest pain, pain when breathing, and they'll have a fever, chills, night sweats, fatigue, loss of appetite, so anorexia, and weight loss. Now, the risk factors for that secondary reactivation would be a weakened immune system. So a patient with HIV or AIDS getting chemotherapy meds, or a diabetic, or an older adult, or an infant. All right, so the geographic risk for TB is highest in countries in Southeast Asia, Africa, and Western Pacific. Now, the factors that increase the risk are traveling, being born in or frequently traveling to a high-burden country, socioeconomic conditions like poverty, being homeless and living in crowded settings like shelters or prisons, poor indoor air quality and crowded, poorly ventilated spaces. Extra dry areas with low annual rainfall show a stronger link to TB risk. Germs can linger in the air for hours. Poor ventilation, like being indoors or closed vehicles, increases the risk. And prolonged close contact, usually more than 8 hours, puts you at risk. All right, so the test they can do is the nucleic acid amplification test, or they can do the tuberculin skin test using the PPD, the purified protein derivative. They also have the quantiferon TB golden tube test. Just remember, the only way to definitively diagnose TB is sputum cultures. 3 sputum cultures on 3 separate days. All right, so the Mantox test, also called the tuberculin skin test, or PPD, they can check for latent tuberculosis infection by injecting a small amount of tuberculin under the skin of the forearm. A positive result is a firm raised bump that's indurated. It's usually red within 48 to 72 hours after administration. It doesn't indicate that you have the actual TB. It just means you've been exposed to it. Okay. So anybody with a greater than 5 millimeter is considered positive if you're in a high-risk group. Okay, so high-risk groups are those with poor immune systems or healthcare workers. Anybody else, it's greater than 10. Okay, so anybody that's HIV positive, recent close contact with someone with TB, somebody with fibrotic changes on the chest x-ray, immunosuppressed patients, everybody else greater than 10. So recent immigrants from high prevalence countries, injection drug users, residents and employees of high risk congregate settings, patients with clinical conditions that place them at high risk like diabetes, leukemia, renal failure, having low body weight. Okay, so these things here. All right, so then it talks about treatment. So you're going to use drugs, combination drugs. Multi-drugs are simultaneously given. Long duration treatment for TB is about 6 to 9 months, but can be extended up to 2 years if it's the drug-resistant form. Common drugs include INH, which is isoniazid, also rifampin, pyrazinamide, and ethambutol. Usually the best therapy for a patient with TB is called DOT, or direct observation therapy. That's where you watch them take the med to ensure they complete the full course, because a lot of patients don't want to because of the side effects. Treatment for latent TB is shorter, more effective regimen, about 3 to 4 months. Yeah. All right, so then it goes into talking about rhinosinusitis. This is commonly known as sinusitis, inflammation of the nasal and sinus linings. It causes congestion, facial pain and pressure, thick nasal discharge, and reduced smell. It's often triggered by viruses like colds, but also bacteria, allergies, or fungi. It's categorized as acute, which is short-term, often following a cold, or chronic, which lasts more than 12 weeks. The treatment is warm compresses, steam, and saline, medications, nasal corticosteroids, decongestants, and antibiotics. And if that doesn't work, then procedures like sinus irrigation, endoscopy, or surgery for severe cases. Okay, what's going on over here? All right, so then it talks about a peritonsillar abscess. This is a painful pus-filled pocket near a tonsil. It often is a complication of tonsillitis. It causes severe sore throat, muffled voice, and troubled swallowing or opening the mouth, requiring urgent treatment like needle drainage, incision, and antibiotics to prevent serious infection. It's most common in teens and young adults, but it can affect anyone. Guess I have to roll this now, huh? Okay, then you've got inhalation anthrax. Okay, this is highly tested. You can get this from the soil, contaminated animal products like wool, hides, or hair. It can also be used as a bioterrorism weapon. The deadliest form of anthrax occurs when someone breathes in the Bacillus anthracis spores. This leads to severe lung damage, respiratory distress, shock, and often death, even with aggressive treatment. The fulminant stage begins after the patient feels a little better. Usually there is a sudden onset of severe illness, including respiratory distress and hematemesis, bloody vomit. Also dyspnea, diaphoresis, stridor, chest pain, and cyanosis. They'll have a very high fever, maybe some hemorrhagic mediastinitis, and pleural effusions can develop. As the infection spreads through the blood, septic shock and hemorrhagic meningitis can develop, and death can occur within 24 to 36 hours, even if antibiotics are started in that stage. So that's a very rough stage. Yep, I'll be rolling it. All right. So then it just talks about the causative organism of respiratory infections is common in geographic location. Adult living in the area may develop immunity over time, and if they get treated, it'll depend on the type of organism. All right, so then it just goes into a case study. Okay. Nothing to answer here, but then it does ask here, which vital sign or test result requires immediate nursing intervention based on what we saw? All the vital signs are abnormal. However, the most important one is the increased respiratory rate and decreased oxygen saturation. Okay, even though a diagnosis has not been confirmed, it's important to address tachypnea because they're not exchanging any gases breathing that fast. All right, then we've got the next question, which order will a nurse implement first? All orders are very important, but the oxygen therapy is the most important. So it's very important that supplemental oxygen is started because of the hypoxia. Okay. All right, so C would be the answer there. All right, then we've got what intervention will the nurse implement at this time? The client has developed problems with their airway. So you need to help them cough and deep breathe at least every 2 hours. Teach them about incentive spirometry every hour while they're awake, and encourage them to consume 3 liters of fluid. Monitor INO and give them a bronchodilator if ordered. All right, and then we've got this one. Okay, so it says, for which symptom will the nurse assess? Select all that apply. It's A, fever, B, cough, C, confusion, and D, weakness. All right, then it's got another one. Okay, it says a client for whom the nurse is caring is diagnosed with rhinosinusitis. Which symptom does the nurse anticipate will be found upon assessment? And that is all of those, A, B, C, D, E, F. Okay. And then the last one. The answer, you will need two vaccines to best protect yourself. Okay, so A should have been the answer there. And then we'll move along to chapter 26. Care of patients with respiratory emergencies. Hold on a second. All right, very good. So it talks about a pulmonary embolism. Okay. It says collection of particulate matter that enters the venous circulation and then lodges in the pulmonary vessels. Any substance can cause an embolism. Blood clot is the most common cause. Let me see what's going to roll. All right. So there's the image to the right shows a little picture of an emboli with an infarct, meaning it's cutting off oxygen in tissue or dying. Okay. All right, so the risk factors. It says immobilization increases the risk of PE because it slows blood flow, causes stasis, allowing blood in the deep veins, especially in the legs, to pool and clot, often forming the DVT. That DVT can break off and travel to the lung. So, a central venous catheter. The catheter can irritate the vessel lining, slowing blood flow and creating the surface for clots to form, a process influenced by what's called Virchow's triad, with risk increased by factors like catheter size, infection, cancer, and chemotherapy. Surgery is a major risk factor for pulmonary embolism because it causes blood to pool from inactivity. It damages blood vessels and triggers the body's clotting system, forming the DVT in the legs or the pelvis, and that can go to the lungs, especially after orthopedic, abdominal, or pelvic procedures. Pregnancy increases pulmonary emboli risk due to a natural state of increased blood clotting called hypercoagulability. For blood loss during childbirth combined with slow blood flow from the growing uterus pressing on the pelvic veins and reduced mobility, creating conditions that can ripen a clot. Also, obesity raises PE risk. Excess body fat triggers chronic inflammation and alters clotting mechanisms, making blood more prone to clotting and harder to dissolve clots, while also leading to sluggish blood flow in the legs, setting the stage for clots to form. Advancing age is a major risk factor for PE due to a combination of age-related bodily changes, increased prevalence of chronic illnesses or comorbidities, and a higher rate of immobility. All right, so lifestyle changes. It says hormone replacement therapy raises PE risk because estrogen creates a prothrombotic state, making blood more likely to clot by increasing clotting factors 7, 10, and 13, and decreasing natural anticoagulants like protein S and antithrombin. Oral hormone replacement therapy boosts these clotting factors significantly. All right, so pulmonary embolism, what are we going to see in the respiratory system? They're going to have dyspnea, tachypnea, tachycardia, pleuritic chest pain, dry cough, hemoptysis. And the cardiac system, they're going to have distended neck vein, syncope, cyanosis, systemic hypotension, abnormal heart sounds, abnormal EKG, hypoxemia, which can trigger anxiety and a sense of impending doom. Okay. All right, so here's the anticoagulant heparin. You got to know When we give heparin, we're looking at that APTT. Okay, so just go through that, learn that table. All right, it says we use heparin. Remember, heparin is acute. Okay, it doesn't dissolve already existing clots. It just makes the clots that are existing not able to get bigger, and it prevents new clots from forming. The tissue plasminogen activator is the thrombolytic or the clot buster. Okay. Okay, that's just a problem there for your math. You can do that math. All right, so then it just talks about fibrinolytics, things that break up clots, the TPAs. Just remember, you got alteplase, streptokinase, urokinase, retroplase, tenactoplase. So they either have kinase or place. Okay. All right, so then it talks about acute respiratory failure. That's a life-threatening condition where the lungs suddenly can't provide enough oxygen or remove enough carbon dioxide, which leads to low blood oxygen, hypoxia, and potentially hypercapnia or high carbon dioxide. This causes confusion, extreme tiredness, and bluish skin, and it can trigger more severe illness like pneumonia, sepsis, trauma, or COVID-19. Okay, it requires immediate emergency care, often involving oxygen and mechanical ventilation. All right, so then we get an acute respiratory therapy. It says, what do? We can put them on oxygen therapy, supplemental, or through CPAP, continuous positive airway pressure, or BiPAP. Also, we can use mechanical ventilation. We may have to intubate and mechanically ventilate, and then treat the cause. Antibiotics for infection, bronchodilators, corticosteroids, and address the underlying cause. Okay. All right. Acute respiratory distress syndrome is a severe life-threatening lung injury where fluid leaks into the lungs' air sacs, the alveoli. This prevents oxygen from reaching the bloodstream and causes dangerously low oxygen levels, often triggered by sepsis, pneumonia, trauma, or aspiration. Okay, so the pulmonary capillary wedge pressure, ARDS, typically has a low pulmonary capillary wedge pressure, so it's not able to receive the blood through the pulmonary artery and process it forward and oxygenate it and process it back to the left side of the heart. So it can cause a type of heart failure called cor pulmonale, because it's going to put pressure on that right ventricle. So when the pulmonary capillary wedge pressure is elevated, it suggests some type of heart failure. Vital signs typically show tachycardia, tachypnea, and low oxygen saturation, often accompanied by low blood pressure. As the condition worsens, all signs of severe distress are going to be caused from poor oxygenation. All right, CPAP, we talked about it. That's continuous positive airway pressure. And then there's a setting on the ventilator called the PEEP. That's the positive end expiratory pressure. That's where they're going to force the alveoli to stay open longer so that you can expel more carbon dioxide. So fluid management, recommended after initial resuscitation to avoid fluid overload, which can worsen lung edema, by aiming for a near zero or negative fluid balance. Diuretics may be used to remove excessive fluid, especially with volume overload. Sedatives and neuromuscular blockers can reduce agitation, ease ventilation, and lower oxygen demand. Also, we're going to be giving analgesics for pain, antibiotics, blood thinners to prevent DVT and PEs, acid-reducing agents, so the proton pump inhibitors to prevent stress ulcers. And your nutritional therapy for ARDS focuses on early enteral feeding within 24 to 48 hours using standard formulas, but we have to avoid overfeeding to manage that hypermetabolic state. Okay, there's a picture of an endotracheal tube, and there's a picture of a ventilator. Remember, they have to verify placement, assess breath sounds bilaterally, look for symmetric chest wall, make sure air is emerging from the ET tube. Okay. Now, there's different settings on the ventilator. The assist control is a full support mode. The ventilator takes over the work of breathing for the patient. Synchronized intermittent mandatory ventilation is similar to the assist control in that the tidal volume and ventilatory rate are preset. If the patient does not breathe, the ventilatory pattern is established by the ventilator. But what makes it different from the assist control, it allows spontaneous breathing at the patient's own rate and tidal volume between the ventilator breaths. It can be used as a main ventilatory mode or a weaning mode. Pressure support ventilation is used for spontaneously breathing patients. And the CPAP and BiPAP are non-invasive pressure support modes used for spontaneously breathing patients. Okay. All right, so then it talks about peak airway pressure. This is the pressure used by the ventilator to deliver a set tidal volume at a given lung compliance. It appears on the display of the ventilator. It's the highest pressure reached during inspiration. Trends in the peak airway pressure reflect changes in resistance of the lungs and resistance in the ventilator. An increased reading means increased airway resistance in the patient or the ventilator tubing, such as a bronchospasm or pinch tubing, patient biting the tubing. Increased secretions, pulmonary edema, or a decreased pulmonary compliance. The lungs or chest wall is stiffer and harder to inflate. Now, an upper pressure limit is set to prevent barotrauma. When the limit is reached, the high pressure alarm sounds and remaining volume is not given. We talked about that PEEP setting. It's positive pressure exerted during expiration. It improves oxygenation by enhancing gas exchange and preventing atelectasis. All right, so the ventilator-associated events is a broad term for complications from mechanical ventilation, replacing older, less precise definitions like just ventilator-associated pneumonia. It includes both infectious, like pneumonia, and non-infectious, like pulmonary edema, atelectasis, fluid overload. So the key classifications for the CDC, the ventilator-associated condition is respiratory worsening defined by sustained increases in daily minimal PEEP greater than 3 centimeters of water, or the forced inspiratory oxygen greater than 20% for at least 2 days. Infection-related ventilatory-associated complication, a plus sign of infection, fever, low temperature, abnormal white blood cell count, and new antibiotic use for greater than 4 days. And then you got possible ventilator-associated pneumonia, which meets the criteria and has specific microbiological or histopathological evidence of lung infection. All right, so ventilator care, you see what you're supposed to do. Make sure the device is secured. Assess placement of tube. Document in centimeters at the client's lips or teeth. Wrist restraints may be required to prevent accidental extubation. Suction is needed. Assess respiratory status every 1 to 2 hours and monitor those vent settings. Okay. Also, reposition the ET tube every 24 hours to the opposite side to prevent skin breakdown. Also, the stress ulcers, prevent them by giving a proton pump inhibitor and elevate the head of the bed at least 30 degrees to prevent stasis and pneumonia. All right, these are the complications: cardiac, lung problems, GI nutritional problems, infection, muscle deconditioning, and ventilatory dependence. All right, so the image to the right is an x-ray of barotrauma. Note the air in the neck arrow as a consequence of ARDS in a client receiving positive pressure ventilation. Ventilator-associated barotrauma is a form of ventilator-induced lung injury. It's caused by high airway pressure. It results in physical damage to the lung tissue. It occurs when alveolar rupture causes air to escape into the surrounding extra alveolar spaces, leading to conditions like a pneumothorax, a pneumomediastinum, or subcutaneous emphysema. Okay, so this is extubation. You're going to hyperoxygenate, thoroughly suction the ET tube, rapidly deflate the ET cuff, remove the tube during exhalation, instruct the patient to immediately cough, Continue oxygen by face mask or nasal cannula, and monitor the client every 5 minutes. Assess ventilatory pattern for any respiratory distress. Okay, then you've got chest trauma. That's a contributing factor in about 50% of deaths of patients who experience unintentional traumatic injuries. Okay, a pulmonary contusion. That's a potentially lethal injury, even though it's a bruise. It may be asymptomatic at first. Later, it can develop respiratory failure and pneumonia. So the patient will present with decreased breath sounds, crackles, wheezing, and the treatment is maintenance of ventilation and oxygenation. All right, so then it talks about chest tubes. A chest tube is a catheter inserted into the pleural space and the chest cavity, also referred to as the thoracic cavity or the thorax. The purpose is to remove air, blood, or fluid. When a lung collapses due to leaked air into the pleural space, it's called a pneumothorax. And when it collapses due to blood in the pleural space, it's called a hemothorax. And these are treated with insertion of a chest tube. Now, that chest tube will have a collection chamber. The chest tube exits the incision from the patient's chest wall and connects directly to the collection chamber to collect drainage from the pleural space. The collection chamber is calibrated so that the drainage can be directly measured in the device. The outer surface of the chamber has a surface that can be written on to document the date, time, and amount of fluid collected. The chamber is typically on the far right side of the system. It also has a water seal chamber. It has a one-way valve that allows air to exit the patient's pleural cavity during exhalation, but does not allow it to re-enter during inhalation. The water seal chamber is filled with sterile water and maintained at the 2 centimeter mark to ensure proper operation. This level should be checked regularly and filled with additional sterile water as needed. The water in the water seal chamber may rise with inhalation and fall with exhalation. That is called tidling. Tidling indicates patency of the tube. However, continuous bubbling in the water seal chamber, that indicates an air leak. Now, the suction control chamber, not all patients require suction. If a patient has suction ordered, the amount of suction should be prescribed by the doctor. There's 2 types of suction systems that can be used, referred to as wet suction or dry suction. Wet suction controls suction by the level of water in the suction control chamber, and it's typically set at -20 centimeters for adults. If there is less water in this chamber, there is less suction. There should be gentle bubbling in the chamber because it is directly attached to a suction device. However, excessive bubbling can cause rapid evaporation of the water. A dry suction system uses a regulator to adjust the amount of suction and also responds to air leaks to deliver consistent suction for the patient. All right, so then it talks about a condition called flail chest. This is a severe life-threatening chest injury from multiple rib fractures, usually 3+ ribs in 2 different spots. It'll cause detachment segment to move paradoxically, meaning inward on inhalation and outward on exhalation, leading to severe pain, breathing difficulties, and poor oxygenation. So the treatment is immediate care, oxygen, pain management, and sometimes assisted ventilation. Hospitalization may be required for stabilization, often with a mechanical ventilator. Surgery can be needed to fix any broken ribs and stabilize the chest wall, reducing pain and improving breathing. Now, complications of a flail chest are a pneumo or a hemothorax, pulmonary contusion, a respiratory failure, or even shock. Okay, so you see air enters the space between the lung and chest wall but can't escape. This creates a one-way valve that progressively collapses the lung and shifts the heart and major vessels, causing severe shortness of breath, low blood pressure, and potentially cardiac arrest. Tension pneumothorax. So the treatment is immediate needle decompression. A large needle is inserted into the chest wall to release the trapped air, converting it to a simple pneumothorax. Then they'll need a chest tube. A tube is then placed to drain air and allow the lung to re-expand. They'll also need supplemental oxygen. You have to avoid positive pressure ventilation until the tension is relieved because it will worsen the condition. All right, then we got some questions. The answer here is A, a 24-year-old male admitted with blunt chest trauma and aspiration. Okay, then we got another question. The answer here is B. I should drink more green tea and cranberry juice. And then the final question is D. Opioid analgesic overdose. So that completes 26 part 1, but there's also a 26 part 2. Concepts for requiring oxygen therapy or tracheostomies. All right, so we'll move to this one. Okay, and that is oxygen therapy. Remember, maintain oxygen saturation, keep blood oxygen levels within target ranges, which is 95 to 100% for NCLEX. All right, so then it goes into the difference between respiratory acidosis and respiratory alkalosis. Remember, an ABG shows respiratory acidosis. It indicates a low blood pH, less than 7.35, due to high levels of carbon dioxide, greater than 45. An arterial blood gas shows respiratory alkalosis with a high pH, greater than 7.45, and a low PaCO2, okay, less than 22. Okay, with a low PaCO2 less than 35. This results from hyperventilation, blowing off too much carbon dioxide, leading to increased alkalinity. All right, so the hazards with oxygen therapy: frayed cores, open flames, gas ovens or heaters. Lubricate only with water-based lubricants, petroleum-based or flammable. No smoking, make sure they got signs posted, and store the oxygen cylinders in a dry, cool area. Okay, so what combustion? Ensure that there's no smoking and that no other sources of sparks or flames like candles or matches are used, because that can cause combustion. Toxicities of oxygen symptoms start with dyspnea, a non-productive cough, chest pain beneath the sternum, GI upset, and crackles on auscultation. As exposure to high levels of oxygen continue, problems become more severe with decreased vital capacity, decreased compliance, and hypoxemia. Atelectasis symptoms start with dyspnea, non-productive cough, chest pain beneath the sternum, GI upset, and crackles on auscultation. As exposure to high levels of oxygen continues, problems become more severe with decreased vital capacity, decreased compliance, and hypoxemia. Mucous membranes detected as crackles and decreased breath sounds on auscultation. And to prevent infection, keep humidity, nebulizer water clean, because you don't want bacterial or fungal infections to grow. All right, so type oxygen depends on required oxygen concentration. Okay. All right, low flow oxygen delivery systems are easy to use, comfortable. That's a nasal cannula or a simple face mask, partial rebreather or a non-rebreather. Just remember, you need to humidify oxygen at 4 liters or better. Okay. Now, the nasal cannula is lightweight, portable, and allows for eating, drinking, and talking. But the downside, nasal issues like dryness, irritation, congestion, runny nose, or even nosebleeds, especially with higher flow rates, it limits oxygen precision. It can only go up to 6 liters. Okay. All right. So there's your simple face mask. Benefits: provides more oxygen than a nasal cannula. Can go 6 to 10 liters. Good for mouth breathers. Effectively delivers oxygen to those who breathe primarily through their mouth. It's simple and readily available, easy to apply, and commonly used. Can often have a nebulizer attachment for breathing treatments, but there is a low CO2 risk with proper flow. Side vents allow exhaled air to escape, preventing suffocation if flow drops. Drawbacks: it interferes with activities, must be removed for eating, drinking, or talking. It's confining and uncomfortable. It can feel restrictive or claustrophobic. It requires proper seal. It leaks, allow room air in, diluting oxygen, so it may need taping for a good fit. It's not for high concentrations because it cannot deliver very high or precisely controlled oxygen levels. Can cause skin irritation, especially with prolonged use. Requires minimal flow. Needs at least 5 liters minimum to prevent rebreathing exhaled carbon dioxide. All right, then you got the partial rebreather. Rebreathing some exhaled air reduces the amount of fresh oxygen needed, making it efficient. It stimulates breathing. Rebreathing some CO2 helps maintain the drive to breathe, especially for patients with low respiratory drive. There's no suffocation risk, unlike a non-rebreather. If the oxygen flow is too low and the bag deflates, the patient can still breathe room air through the side ports, preventing CO2 buildup. There's variable oxygen levels. The amount of exhaled air rebreathed changes with patient ventilation, making the fraction of inspired oxygen inconsistent. It interferes with activities. It cannot be used for eating, drinking, or talking. Not for highest needs, doesn't reliably deliver the very high oxygen concentration needed for severe hypoxia, unlike the non-rebreather. There is a potential for CO2 rebreathing. So those are the drawbacks. All right, then you got the non-rebreather. There is a suffocation risk with this. If the oxygen tank empties, the one-way valve prevents inhaling room air, leading to suffocation, so it requires constant monitoring. Discomfort and impracticability, can feel hot, confining, and prevents eating, drinking, or talking. Inconsistent delivery. Actual oxygen levels vary with mask fit and patient's breathing pattern. It can pull in room air and reduce the FiO2. It delivers unhumidified cold oxygen, which can irritate airways and increase insensible water loss. All right, then you got the high flow nasal cannula, 30 to 60 liters a minute. Combination of heat and humidity, which minimizes damage to the mucous membranes. Now, the most accurate mask is the Venturi. By controlling the FiO2, it helps prevent hypercapnia, excessive carbon dioxide, uses color-coded adapters to easily switch between specific oxygen percentages. But it does interfere with eating, talking, obstructs the mouth, making it difficult to eat, drink, or communicate clearly. It does have higher flow rates, requires higher oxygen flow from the source to achieve the Venturi effect, and it can cause dryness of mucous membranes, sometimes needing humidification. Then you got the T-piece. Okay, delivers decreased forced inspiratory oxygen to clients with tracheostomies, ET tubes. The aerosol should appear on the exhalation side. All right, then you've got the CPAP, BiPAP. The BiPAP delivers a high pressure for inhalation and a lower pressure for exhalation, actively assisting breathing. The CPAP delivers a single constant level of pressure to keep the airway open, primarily for oxygenation and preventing collapse, but less for assisting ventilation. All right, so then it just talks about care coordination, and it says focusing on safety equipment, pulse ox, flow rates, patient family education, medication management, and ensuring smooth transfers to prevent complications like hypoxia, using tools like pursed lip breathing for better outcomes. Key aspects include proper application, monitoring safety, so checking for kinks, don't use extension cords, and teach techniques like coughing and ambulation for effective oxygenation. All right, then it just reviews the metered dose inhaler. Remember, this is a pressurized canister. It holds liquid medicine and propellant. Pressing the canister releases a puff of aerosol medicine. You must inhale deeply and slowly through the mouthpiece at the same time the canister is pressed. Spacers can be used to hold the medicine mist, giving you more time to inhale and reducing the medicine in the mouth of the throat. Prepare, remove the cap, shake the inhaler, and check for debris. Then you got to prime it. If new or unused for a while, spray a couple puffs in the air. Position, stand to or sit up straight, tilt the head back slightly, place the mouthpiece in the mouth and seal lips around it. Then inhale and press. Breathe in slowly and deeply through your mouth as you press the canister once. Hold your breath, remove the inhaler and hold the breath for up to 10 seconds. And exhale and repeat. Breathe out slowly and wait about a minute before a second puff. And then rinse your mouth and spit out the water if it's a steroid. You'll get a nasty fungal infection. All right, let's talk about a tracheostomy there. Pre-op focuses on knowledge deficits through teaching and discussing trach care, communication, and speech. After the trachea is inserted, the ET tube is removed while the tracheostomy tube is inserted. The tracheostomy tube is secured in place with sutures, and the tracheostomy ties are Velcro tube holders. And a chest x-ray determines proper placement of the tube. Focus care on ensuing a patent airway, confirm the presence of bilateral breath sounds, and perform your respiratory assessment at least hourly, and assess the patient for complications from the procedure. Okay. The complications: obstruction from mucus or blood, decannulation. Tube dislodgement in the first 72 hours after surgery is an emergency because the tracheostomy has not matured and replacement is difficult. The tube may end up in the subcutaneous tissue instead of the trachea. This is referred to as a false passage, and the patient will not be able to be ventilated. If the decannulation occurs after 72 hours, you can extend the patient's neck and open the tissues of the stoma with a curved Kelly clamp to secure the airway. With the obturator inserted into the tracheostomy tube, quickly and gently replace the tube and remove the obturator. Check for airflow through the tube and for bilateral breath sounds. If you cannot secure the airway, notify a more experienced nurse or respiratory therapist or a respiratory healthcare provider for assistance. Then ventilate with bag valve mask. Secretions or by cuff displacement indicators are difficulty breathing, noisy respiration, difficulty inserting a suction catheter, thick, dry secretions, and high peak pressures if a mechanical ventilator is used. Okay. All right, so it says care for issues for the patient with a tracheostomy. Bypassed upper airway. The trachea bypasses the nose and mouth, so inhaled air is cold and dry. Thick secretions. Lack of humidity can cause secretions to become thick, tenacious, and crusty, obstructing the tube. Impaired mucociliary clearance. Cilia and the airway can't function properly, preventing natural mucus removal. The risk leads to inflammation, increased infection risk, atelectasis, and potential blockage. You need to clean the skin around the opening daily with sterile saline water to prevent irritation and infection. Change the dressings as needed to keep the area clean and dry, and watch for redness, swelling, heat, foul odor, or drainage. You can use heated humidifiers or heat and moisture exchangers, especially with supplemental oxygen, to add warmth and moisture. All right, so it talks about trach suctioning, what you're going to need, what you're going to do. Remember, don't suction more than 2 passes. Only suction coming out no longer than 10 seconds. You got to auscultate the lung sounds first, and then you hyperoxygenate before and after. All right, so then it just talks about providing bronchial and oral hygiene. It talks about nutrition. Food is often soft, moist, and blended initially, focusing on safe swallowing with a speech pathologist guiding diet progression. When they eat, they need to be upright, small bites, avoiding crumbs or thin liquids to prevent aspiration in the lung. Bland foods with plenty of fluid and fiber are recommended for comfort and regularity, while crunchy items like nuts, chips, and dry bread are avoided. They may need a PEG tube. For a tracheostomy patient with a PEG tube, nutrition involves specific commercial formulas administered via the tube, often with head elevation during feeds. Okay. These are means you can use for communication if they're unable to talk. Okay. All right, so it says psychosocial needs. It says a visible tracheostomy tube can cause embarrassment, fear of judgment, feeling different, and withdrawal from social activities. Also worry about breathing, supplies, future uncertainty, and dependency can create anxiety. This can lead to powerlessness. Psychological support therapy is crucial to address anxiety, depression, and adjustment issues. And empowerment through education, both preoperative and ongoing training on trach care, like speaking valves, builds independence and confidence. Communication strategies like speech-language pathologists help with voice restoration and alternative communication methods. Social support and connections can encourage connections with support groups, and addressing family-friend perceptions can reduce isolation. Multidisciplinary care, an integrated team of the ENT, the SLP, and the psychologist, is essential for comprehensive management, and addressing stigma education for the public and healthcare providers can reduce differential treatment. All right, so then it talks about weaning, taking somebody off of the vent. Okay. And then it goes into a case study. Okay, so this one requires an answer. The blood pressure is within normal range and only slightly elevated. The temperature is only slightly elevated. Heart rate is elevated. So the nurse should check the client's medications to see if they're on a bronchodilator or another med that could cause their heart rate to increase. The priority concern is increased respiratory rate and decreased oxygen saturation. Okay. The next one is answer D, complete an assessment of airway and respiratory status. The next one is also D, suction the artificial airway and remove the secretions. The next one is a select all that apply. It is answers A, B, and C. Create a sterile field, change trach ties, and remove old sterile dressings. The next question is B, administer oxygen via the Venturi Max. The next one is B, tracheomalacia. And the other one is B as well, oxygenate with 100% oxygen. So this concludes this presentation. I hope it's helpful.